Can pick you, and you'll see on my first slide that my first admission is that I am so not an anesthesiologist, and so my part that I want to talk about is what the experience outside intubations in the OR, what that looks like, and what opportunities that affords us around process improvement. So so I hope that you're inspired to like take on process improvement after this. That's my goal. Sorry, if I were more, I would have a thing to plug in. So I work in the PICU-SUM, and then I've chaired the Code Blue committee for a long time at Children's, which has let me to have the vantage point of seeing pretty much all the arrest data for the last about 15 years here. And so over time, we've gradually improved our ability to extract data around how we're doing with kids at the time of arrest. Granted, it's not as robust a database as we'd like, but it does afford some insight. Okay. So I have kind of boring slides. So that's me, not an anesthesiologist. And so what I wanted to do is, I really it would be absurd for me to talk with the crowd that's here about the specifics, but I did want to talk about how people outside of the ICU might think about taking advantage of the resource, and how our side-by-side presence with anesthesiology, what we might think as a reasonable thing from the outside. When people come here, they expect perfect care. They expect the best care that's available. And so when we're thinking about airway skills, I want to just go through the reasons why this is so important for people who are going to do intubations outside of the OR. So the consequences of errors here are catastrophic. They're not straightforward. IV infiltrate or something else but this has real potential for long-term harm. We know that the experts, the anesthesiologists, are available 24/7 here, and so it would be indefensible for us to say this is why we thought we would go ahead and do this procedure when they're right there and they know this is what they're trained to do. This is the most likely wrongful practice type of suit. It's also the most successful wrongful practice type of suit. So once again, we would have no room to stand on if we said that we felt like we're in the ICU, so we're gonna, or the ED, and we didn't call for help for some reason. And then additionally, we're trying to be as safe as a high reliability organization. So we want to build in pathways so that we constantly have a process for getting the right care to the patient at the right time. So one of the best samples of how big a problem is this was conducted in the UK. This study was completed 2 years ago, and I apologize if you went over this study. So this, the National Health Service, one of the beauties of having a nationalized health service system is that if they say, we're going to study this, then by golly, they study this. So they said that every hospital, 309 hospitals, will collect this data. And they inserted a reporter into each hospital. And the complications that they looked for were major. So the complications had to include death, brain damage, emergency surgical airway, unanticipated ICU admission, or prolonged ICU stay. And they determined that a prolonged ICU stay was greater than a week. And so they collected this data prospectively for a year, and they reported it in 2 articles side by side. And they divided the complications into those that occurred in the operating room and those that occur outside of the operating room. So you can imagine that the bulk of airway management occurs in the operating room. Here, our ratio of sort of intubations inside the operating room to outside the operating room, total for the ICU and the ED, we perform roughly 300 intubations a year. That's what we do. And so you guys probably do more like, I think you do about 12,000 cases. So the number of cases, intubations inside the OR compared to outside is easily, I don't know, like not, is that 100-fold? I mean, it's just tremendously skewed. And when you look at the number of complications as defined by this, they found out of these 309 hospitals, they reported in 1 year 386 severe potential cases, and they reviewed all of those back and forth, and they ended up in the end with 184 events that really met their inclusion criteria. And out of those 184, there is a skewed proportion that happen outside of the OR, given the number of events that occur in the OR compared to outside. So, unfortunately, they didn't count the denominator data. They just present the numerator data. So I can't tell you the exact ratio of if you have this many cases. But suffice it to say that a disproportionate share of complications, severe complications, happen outside of the OR. In the ICU, out of these, 61% led to death or persistent neurologic injury, and 31% of these events led to death or persistent injury in the ED. So these are catastrophic events. Airway events in the ICU and the ED are more likely than those during anesthesia to occur out of hours, to be managed by doctors with less anesthetic experience, and to lead to permanent harm. So if we, it's when we know this, it's incumbent upon us to build a system so that this doesn't happen. And dramatically, failure to use capnography contributed to 74% of the cases. So we'll talk about that a little bit. When you look at what happened to these patients, and I just like this study because it sheds light, I think, on the worst of the issue. Depending on how you define a complication to an airway, I mean, some of the anesthesia literature is counting a complication as a significant desaturation, and this is so far past that. So if you really thought about or expanded the definition of harm to just a severe desaturation, a brief episode of chest compressions, the numbers would really be substantial. But in this study where they're really looking at catastrophic injury, in the ICU, the bulk of them in this particular population were related to tracheostomy-related incidents. But simple things like tube coming out, unable to intubate the patient, esophageal intubation, can't intubate, can't ventilate scenario, airway trauma, and problems at extubation. So all of these seem completely, unfortunately, familiar. And then in the ED, there are things that have roughly the same list, a little bit more common aspiration. And then when you look at the things that happen to these patients in the ICU, this high percentage of folks died. And so I guess coming away from this is just inspiring that we really need to be thoughtful about how we can do better. This paper, and I'm happy to send it to anyone who wants, also went through, and out of these 384 cases, they looked at the level of care, and granted it's not perfect because you're trying to extract from the medical record, but in less than 10% of the time could they document that good care had been provided. So I think we do a fairly, we're probably fairly similar to the UK in terms of our abilities, and I think as a general rule we could certainly do better. So I'm going to just do a little step back. Again, I'm not anesthesia, so I just wanted to make sure that we all recognize that there's two different categories of challenge. There's difficult mask ventilation, and the definition being that, inadequate to maintain oxygenation, stable minute ventilation, or requiring 2 providers, and then impossible mask ventilation denoted by the absence of CO2. And the predictors here being obesity, history of snoring, Mallampati, class 3 or 4, and facial anomalies. Just out of the folks for ICU or ED, does anyone here ever examine for this? I don't think we do a very good job of screening our patients. For anesthesia, do you guys do this in kids?
Every single patient.
Yeah, so I think this sort of represents that we don't have the same level of habit around how we think about screening people for when we should call you.
I mean, I do this before I do a ketamine sedation, but like the likelihood that I'm going to actually have to vague valve mask a ketamine, like we do it when we have the time. Not when we're going to intubate.
I think the other thing is that our patients are frequently moribund, and so we don't have we're not going to cooperate with that kind of nonsense. But again, we don't really have a process to make sure this happens in the event that we could. We don't. And difficult intubation predictors, ASA class 3 or 4, again, Mallampati, limited mouth opening, prominent teeth, all these findings that I think Agnes touched on somewhat. Again, I don't think we have a very rigorous process for screening these. We don't have, and again, it could be because most of the time we're in a semi-urgent, but we could do a better job of screening on admission and think about when we're going to invite help. So again, just making sure that for people who don't do this very often, what that looks like in terms of Mallampati. And I think we frequently rely on what has been listed in the anesthesia record and don't necessarily always know that the difference between Mallampati and the other grading scales is present. We also don't spend very much time understanding the ASA class, and so since this isn't forefront in what we think about very often, we might not necessarily say, oh, we're going to change our practice based on this. We make our own preparations, but I don't think we necessarily consider whether or not we're going to involve anesthesia based on this. So how common a problem is this? I like this study just because it's so simple, and it's hard to believe that we hadn't done it before. So these folks did a 3-year observational study at a children's hospital where they took the patients who were completely healthy, and they had no suspicion that any of these patients should have any problem with bag mask valve ventilation or intubation. And they excluded intentionally everybody who'd ever had problems in the past. And they ended up with this group of nearly 500 kids. And out of this group, they just looked and said, what's the incidence that it turns out to be difficult to bag them? And their incidence was 6%. And then what's the incidence that was actually challenging to intubate them? A little more than 1%. So I guess my point is, even if we had a rigorous screening process, there would still be times when we couldn't pick out who was going to be problematic. The risk factors that they identified were age, that they were going to undergo ENT surgery, and that they received neuromuscular blockade. Not helpful, their BMI was kind of surprising, snoring, asthma history, or their exam. So does that concur with what you guys think of when you're thinking about what healthy kids that come in, that there's about this likelihood that you'll run into problems? Is that how you think about it in your mind, or do you think it's more 1 in 1,000?
I think the PDIR did change my attitude a little bit. It's surprising how small percentage of them had an unanticipated difficult airway. Again,
So a lot less than this.
Yeah. I never knew about this study, and I'm surprised because, as you mentioned, they excluded the ones that the known difficult airways, and our anesthesia literature suggests again, this is very difficult to study, but it suggests that the incidence of difficult intubation in the population is about that 1.2%. So I'm surprised that they found the 1.2% in a subpopulation where the difficult airways were excluded.
That incidence of difficult diagnostic ventilation seems high to me.
Seems high. And I guess the thing for me, these are kids that are going to get, this assessment is made by anesthesiology. I could, so anyway, for what it's worth.
That we're doing the mass
Right, like what's defined as difficult is what I would want to know.
It could be.
That requiring an additional intervention, like addition of an oral airway or a second provider.
Second provider.
Physician or something like that.
Yeah.
That seems.
So I think this just points out how difficult it is to untangle the provider skill, patient characteristic, and the circumstances.
Yeah.
At the same time, I think there's also cases where you think the patient looks completely healthy, has no airway issues or any of the risk factors that you're saying. It just happens to be difficult to mask, I don't think.
Yeah.
I mean, it's not common, but that definitely presents itself.
I guess the point being that no matter how well you screen, you need to have a plan. That's my, and so this is the difficult airway algorithm for adults, and our point when thinking about this at Children's was to not reinvent the wheel, since clearly people have thought about this for a long time, and this is for a similar algorithm that's created around pediatric patients. And what we wanted to do here was build an algorithm that was less complete, recognizing that for the bulk of people in the ICU, and actually for everyone in the ICU and the ED, we would not have skills to perform, really any of the fiber optic or surgical approaches. So how, and given the presence of anesthesia here 24/7, what's a reasonable flow so that there's an opportunity for trainees and ED and ICU folks to continue with intubation, but not get to the point where it's unsafe for the patient. So what our algorithm right now for Seattle Children's looks like is in the case of cardiac arrest, then the most experienced person available should do the intubation. And so when the code pager goes off, the default is that anesthesia owns the airway. That's not a good training moment. We've had times when it's been used as a training moment, and then if a patient has a bad outcome, the trainee feels that their lack of skill contributed to that bad outcome. So it's really not a good time to do teaching. So in a non-emergent case, if we had improved screening and there was concern for difficult airway, then the idea is to stop and ask anesthesiology to at least be present and help think about this. If there's no concern, then the 2 attempts by a trainee, and if those 2 attempts are not successful, then stop and call for help. The option here to attempt again is really based at the presence of the person supervising. In the ICU, what we've tended to do or tried to do is say that after 2 attempts, assuming that our fellows and our attendings actually have relatively similar level of skill by the time they're second or third year fellows, that then we're going to just place an LMA and wait for anesthesiology to come. And so one of the things that we've really been trying to do is make sure that all of our providers are expert at LMA placement. If that's our rescue therapy, we should really know how to do that well. And then the next thing would be maybe anesthesiology would come at that point and figure out a different positioning or different equipment and pursue with either direct laryngoscopy or the glide scope at this point. If their determination is that they want more, then the next thing is to obtain the fiber optic equipment and proceed here, and then ultimately surgical airway. So this is what, there's a kind of a ad hoc group of folks that's anesthesiology, otolaryngology, the equipment group, the ED group, and the ICU group that's trying to work more towards a unified approach. But granted, we don't have a great system for doing a ton of education, so I don't think this necessarily gets carried out that often.
Joan, I would say
Yeah.
the other thing that comes up with that is,
Yeah.
like we've tried on our recent intubations to like always have an LMA in the room.
Yeah.
We do get pushback
Yeah.
sometimes from RT.
Yeah.
Because they're not easily accessible in the ICU.
So one of our little things that we've just succeeded, I don't know if the folks, the anesthesiology folks know, we had woefully old equipment outside of the OR for many years, and with the help of Agnes, we agreed on an institutional approach to purchasing blades, handles. So we had previously nothing that was Green Line compatible, so if our handles got mixed up with your handles or your blades in the processing, nothing would work. So we've gone to a system where everything will be Green Line compatible. We just will be getting rid of bulbs and switching to LED handles, and then stocking LMAs in the code carts as well as just the Airway carts. And we agreed on this is the kind of LMA that we'll have, so just taking an institutional approach it's been very gradual. I don't know what it's like from the anesthesia experience when you arrive and our equipment doesn't look like your equipment and you're sort of wondering like, I know I've talked with several people about why we have are relegated to the equipment we do have, and so it's been really great to have some partnership between the groups so that we end up with something that when you get to the event you recognize the equipment. Yeah.
I'm just wondering, how successful has the LMA been as rescue?
So I can tell you anecdotally it's been hugely helpful in just a temporizing measure until you folks get there and get your equipment. What we used to see anecdotally again is when there was a difficulty in getting an airway at a emergent event, we would see 6, 8, 10 attempts. And again, with this very limited set of equipment, so not much changing between one attempt and the next attempt. So I'll just keep trying with what I have because that's all I have. And so what we've tried to do is at this point have people stop trying, have the patient be even a temporizing fix. LMA, I don't think for the bulk of our patients is a very long lasting because most of our patients, the level of lung disease that we're going to need a lot more pressure than this. But if we just use it as a temporizing measure, it seems like it's going to work great.
What kind of LMAs do you guys have now?
We agreed that we would put the air cues everywhere.
And that's in part to help us out so that we don't have to exchange it. And partly because in the OR we found that it works just as well as the unique or the classic. And just to chime in the LMA question, I think the NAB4 points out that in many airway attempts that ended up in a really bad outcome, LMA was not even tried. And in many cases that didn't have such a bad outcome, but still made it to the study or the registry. Crike was tried in the ED setting or ICU setting even before LMA was attempted. So if you look at it from that standpoint, it's a huge success that now the intensivists use it. But we have to remain humble. I did not expect that slide, but in the last report from the PDIR, we do see a very high percentage of failure of LMA. As these are all kids with difficult intubation, so they have anatomical changes that might not be conducive to good LMA fit.
And the other thing, speaking of temporizing measures, I think the other thing that I would emphasize on this chart is being able to bag mass ventilate adequately while you're waiting for help from someone who has more experience in potentially intubating them or imaging the airway.
Yeah.
I think that's such a, it's not the sexy thing. Everyone wants to intubate and be great at that, but being able to bag mass ventilate is by far a better skill.
I think too we're trying to, it doesn't show on here, but we are trying to reach a state where by calling our anesthesia colleagues earlier and more frequently, that we end up with an opportunity for them to come out of the OR and teach us, rather than necessarily every time that you call them, they're going to swoop in and take your airway experience, because I recognize if there's only 300 of them and there's a lot of us, that giving up, it feels like, oh, if I give this up, I'll be even less competent the next time. So I think the idea is to call them more often and have them watch you and troubleshoot you and help you, rather than, that might not always be the case, but that's one of the goals here.
But just as an FYI, if
Yeah.
a trainee is the only person that shows up, a fellow or
No.
a resident,
Yep.
they will be doing the airway, and they're going to kick you guys out.
Yeah.
That's
And
just
they can
the
still talk
policy.
about what they're doing.
Right. but
Yeah.
they cannot
No, I agree.
supervise.
They're not allowed to supervise.
So, you know.
Yeah.
And you also,
Yeah.
you're probably aware that the person who carries the code pager is a resident who is often a CA2 resident. That means that he's just starting his pediatric or her pediatric anesthesia rotation.
Yeah.
They have 1 year of adult anesthesia experience.
Yeah. But so, I mean, that's a problem, and we can talk about, how that plays out. Okay, so another thing we've tried to do with this group is try to fit the clinical actions here in these boxes with your access to the equipment that you'll need to successfully carry out that step. And so the routine intubation box, this should say intubating LMA, because we're only going to have one kind. We wanted to match the equipment in the rainbow cart to the code cart, and really everything that you need for LMA as well as DL should be in there. And that equipment should be functional across all different places, so that this handle and this blade work. The next thing is the addition of the anesthesia backpack. So when you guys arrive, you're going to bring a little bit more equipment than what's in the code cart, and it builds a second layer of redundancy, just in case. Sometimes there's like 55 code carts, but sometimes it takes a while to get one there, and so your backpack maybe would get there beforehand. Usually the code cart beats you there by quite a bit. And then the difficult airway cart is the next level of equipment, and again, anesthesia would be driving when this would be used. There's 3 carts in the OR and 1 in the ED. We wanted very much to have 1 in the ICU, and we don't have a place to store it, so it doesn't exist. So one of the things when we go and do our simulation to think about is that whole, how am I going to get the difficult airway cart to the ICU, and what does that look like? There are needle cricothyrotomy kits in the ICU, as well as, since you have a difficult airway cart, you guys in the ED have all the needle supplies. And then the surgical supplies, Andy, I think, has gone back and forth about 10 times about whether or not he wanted to just move these patients to the OR or have the surgical supplies in the ED. They definitively don't live in the ICU. And I think at this point he has some surgical supplies down in the ED, but not the full spread. Does anyone have any questions about that?
How would you get the difficult airway cart? Like, say you're in the middle of the night and there's no anesthesia tech, and there's only the person who came to the code.
So
They both
there was some kind of union hiring change thing where now the anesthesia tech is allowed to bring the code or the difficult airway cart to the front door of the OR, but they're not allowed to push it all the way to the ICU or something like that.
I've never heard this.
What?
Oh, really?
Well, and they may not even be there. Like,
They might have.
They're not there anyway.
Okay.
About
So
11.
Yeah, my impression would be that you guys.
Yeah, I would think there's going to be a fellow and or
So if we're doing
Yeah.
a case, and one person's with the patient, and the other person is now at the code, do they then leave the code to go
Yeah,
get
that
the
would be tough.
airway
That would be
Yeah.
the worst case scenario.
Yeah,
I
it
was thinking
seems like an untrained airway person should go retrieve the card.
If they knew where it was.
Right.
They knew where it is, which
Yeah.
we should probably.
It surprises me that in the whole big US,
Point that
there's
out
not a
today.
place to put a tower.
You know, there's a surprising, there's a long laundry list of things that people want to store there that there's not room for right now. We really don't actually have room for the glide scope. It lives on the floor in a circle of tape because there's no storage for that either. So it is really a problem. We've tried the idea of moving the one from the ED up.
Yeah, I remember talking about that.
But my impression is that we're still trying to use the OR one. So this is exactly why we're.
And that question is great. I think during normal hours, we've had plenty of people, someone bring it over, but you're talking about the middle of the night, there's an ongoing
Send like an
case.
extra
And
nurse
maybe
or
our
something.
ICU tech should know where they are.
Yeah,
They're usually available.
they're usually able to run. Do you guys still keep them in the right?
Right outside the
Yeah.
vacuum.
Yeah. So we could
On
find
where
them.
The reason they were on that side was because it was easy to get to the ICU.
Yeah.
When it was close.
So maybe we should do a little teaching of our techs to run over and get them at night. So one of the things that we heard a lot was, can LMEs be used in neonates? The NICU folks really have a very, and is anyone NICU here? Have a very special population, and they have been, I think, it's been slower to catch on the idea of LMA in smaller babies. So I just went through, and the Cochrane Review compiled 5 studies and found, this is in newborns, so no difference between LMA and ET tube where bag mask ventilation was unsuccessful. That actually the rates of successful intubation for trainees were woeful. So 35% of newborns not successfully intubated by trainees with up to 4 attempts. So since if ET tube placement in the hands of a trainee is not so great, they looked at newborns and they 100% on the first attempt, and it was a lot faster. They repeated this study with low birth weight infants, including down to 1,000 grams, and a huge percentage of them on the first attempt. So I guess people might wonder, well, if this is just, again, a temporizing measure, and this is a neonate who's going to need long-term intubation, am I just doing this? But it begs the question of, in the hands of a trainee, maybe this is the better place to start. And then, in a few hours, if there's more expertise, switch over. I don't know if you guys, does anyone have thoughts on that? We don't, I think this is more sort of the whole thought around delivery room activity, and is there a role for LMA rather than endotracheal tube, particularly for trainees?
My only one thought on that is, in terms of if you insufflate the stomach,
Yeah.
anytime you're going to make it more difficult, especially in neonate, to ventilate them.
Mm-hmm.
And I'm sure you're right, it's probably easier to place an animal
Right.
in those cases, but that would be something to be concerned about
Yeah.
in terms of ventilating.
Right. So would it,
neonate
yeah.
with an element.
Do you know if the LMA is small enough for the low birth weight? Are those compatible with something that you can exchange?
I don't know that.
The camera?
Surprising, a DD fiber optic?
No, and you would just take it out and intubate.
Yeah.
Okay.
Well, there was a study, I think it's out of China, where they looked at neonates that were having trouble breathing initially. And so after initial resuscitation attempts, they went to either face mask ventilation or LMA. And the LMA kids avoided tracheal intubation for the most part, did very, very well.
Yeah.
So it's kind of surprising.
Yeah. So just maybe the algorithm needs to have a trial of them. Maybe it's just sort of TTNB or just a brief. Anyway, just something to think about. I'm not sure what the. I also wanted to just touch a little bit. Both the ICU and the ED have purchased glide scopes. I don't think we've had adequate opportunity to really become facile with using them. It's terrific that we have the Airway practice room, but again, so there are potential complications there. And my impression is, my impression is just in general that for older kids, once this is easy for you, that it's really a great thing, less straightforward in littler kids, and that while it's easier to see, a little harder to pass the tube. So I don't really know if we'll ever have an opportunity to get enough experience to become expert with the GlideScope in the current way that, level of opportunity that we have. So we'll see. So I just wanted to pull for you, or just show you. So this is the kind of data that we keep for the code committee. So this is an extract of 3 months of data, and what I didn't pull up any of these. If anyone's interested in this, we try to review all the difficult or recurrent intubation cases at our difficult airway work group. This is just a sample. So my guess is that these are all at codes that are requiring multiple intubations, and I think this kind of scratches the surface of the number of times when intubation could go better. So this is ones where there's definitively CPR associated with it. And so I think the need for refining our process and making sure that we do the best we can is evident. So some of these are 6 and 8 attempts, and those are the specific things that we're really trying to avoid. So recommendations to consider. So some of this is just really hard to believe that we don't actually do this yet. So intubation checklist, this would be helpful for both the physicians, nursing, as well as RT. We should have a checklist. You guys are the maestro of checklists. So we don't have one, and we should. We should have an algorithm which is what we've tried to create. I don't think we do necessarily a good job of keeping that algorithm in the forefront and making sure that we have the supplies dictated by the algorithm. We should be doing much more rigorous screening and making sure that we have a plan. And we're getting better, but communicating to the oncoming staff it's not hardwired. So we are relying on some paper signs that say, if somebody has a very difficult airway, and we're pretty good about making sure that we sign those out. There's not a good process hospital-wide for that sign to follow the patient to the floor. There's not any kind of method right now for that awareness that this patient would have a difficult airway to live in the electronic medical record in an easy, uniform place to find that. So all of that work could be better. Capnography. We should have capnography available for all intubations. We should have capnography present for the duration from intubation to extubation. It should be a continuous part of what we do. You guys probably think, what are they doing over there? But we don't have CO2 present, monitoring present on our monitors right now. We're reliant on a mix mash of portable and tidal CO2 monitors that have varying types of technology. Some of them need calibration, and the gizmos that attach to the tubes don't all match up. So, and then for arrests in the cafeteria where PALS is going to dictate that you're going to follow your CO2, we have these tiny little portable capnograph things that you can't really see the waveform. And so we're just woefully behind, and we really need, in all settings, capnography that is standardized. And we should train people. We don't do a very good job, at least in our area. What do these different waveforms mean?
Does the new ED trauma base, do they have capnography on the screen?
We have
I think
it.
they do.
Yeah, you guys do. So just a terrific example. We move patients all the time to IR and here and there, and our transport monitors don't have capnography.
We don't either.
And so then here you are moving patients back and forth,
At a
and
critical time when you should be monitoring whether
Exactly.
the ventilation is continuous.
so we need the an institution-wide microstream technology that's instantaneous without calibration in all settings.
Abby, do you use capnography in your sedations as well?
We do.
Yeah.
Yep.
Other places in the hospital, and it's you guys are kind of ahead of the curve. Other places, so then the treatment rooms, there's not monitoring. So other places, it's not happening as well. We should have access to. I just couldn't take out the word trolley, so I left it in there. So we're getting better at this. I think if we did have a place, and we asked for 5 difficult airway carts, and we got 4. But so the ED is ready. We're not so ready. We're working on making sure that it gets checked regularly. I think was that you that pointed out that the jet ventilation stuff was not had not been checked and was missing, and so the process for getting the cart maintenance and making sure that all the parts are there. I probably need that.
Incredibly embarrassing, but yesterday I went to check our difficult debit cards, and we have 3. One of them is still missing the jet ventilation. So does the ED card. And I periodically, every few months, I check them, and last time I checked them, they all had it. And so yesterday I asked around, and nobody could tell me where they went. This is very embarrassing, and it's a huge problem for this area.
And those are kept in a secure location. The code cards that are kept out and about, stuff just flies off of those. Like, we tried to put these super cool clocks on them, and we glued them to the back, and they still got pried off. So it is really hard to keep stuff unless it's a challenge, because if you tuck everything away and you like put tape all over it and have it secure, then it's hard to get at it. Again, fiber optic scope should be available. So what works well? Preparation works well, communication works well, checklists work great, practice, simulation, that's what we're going to do today. Deference to experts, we're really trying to have a united front. So when we go to Capitol and we say, it'll be like $4 million to get the entire hospital one type of end-tidal CO2 monitoring so your monitors, your X2s, our monitors, your stuff, will use the same technology. We need to defer to the experts, so we've really tried to have Agnes and help us say we commit that we won't change our mind in 2 years and say we actually want this now. So we've really tried to defer to the anesthesia and ENT group that if you tell us this is what we're going to get, we're going to buy it for everybody, and we won't ask again for a few years. So that's sort of the state of that. And then anticipate badness. So that's all my part. I don't know if anyone has any questions about just the practical pieces.
Did you guys talk about ways to convey the difficult airway information for patients that have left the ICU and are no longer intubated?
We have tried. So my heat ticket for putting the difficult airway on the banner or the as a risk somehow got lodged behind spine at risk in terms of level of importance. And then after spine at risk got through, it was supposed to happen next. And then it got sidelined because of whatever the order thing you guys are doing now.
We're switching over to electronic records.
Yeah, and so there needed to be a sync between whatever you're going to do for records and that. So I don't think it's super far away. So we're really relegated to paper right now. Having a paper process is just so fraught with error. So Andy's thing is this board. And so what we're trying to build right now around at least the population, that's the fresh, relatively fresh trachs, is this equipment board, and the RTs are building it, and it basically has, it's sort of a real visual way to show this is the stuff that you should need at the bedside, and a there's a section of it that has a laminated picture of the places where each patient's airway is occluded. So where, if this is your sort of prototypical airway, where is the blockade and what should you do? And so that picture, at least for that population, and then the equipment would have its little outlines like a garage, tool thing. And that board would follow the patient around. That's kind of, we're going for a super low tech because we can't get in line for the high tech.
I mean, if nothing else, can it go on the patient summary where they've got, the Casper or blah 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 and spine at risk, and it can't go there?
It's just been in line. It's been in line for over 3 years. So I don't even know how to say the relative importance of Casper compared to the airway. It just it makes me bananas.
I totally agree. They've been working on that for a while.
How can you be that hard? We decided to do it 2 months later. Done.
You'd be surprised.
I don't know. And then, so I guess one thing is there's so much opportunity here for us to do a better job around any little piece, like just having 3 or 4 pictures of what the capnograph waveforms look like. Put those up on the wall for a few months, quiz each other, make sure that we understand that. Just, there's so many ways that we could be doing a better job around this. That's.
Thank you.
Yeah, thanks you guys.
So I'm just gonna make everyone grab the evaluation form, hold on to it, turn it into us at the end. Just hand it back. It'll take 5 minutes to complete it. So if you want to grab your stuff, we're gonna move to the old ED